we did learn a lot about them. I thought those both sets of presentations were very interesting and informative in terms of going forward. Let's turn our sights real quickly to from sort of the plan side to the purchasing side. And we've asked Blair Childs, who's Senior Vice President of Public Affairs for Premier Health Alliance, to come address those issues. He's their primary spokesperson and communication strategist for Premier and liaison to the Congress, White House, healthcare policymakers. I first met Blair when he was a major executive for AdvaMed, and so he has a long history of an experience in medical technology related issues. And he was with us most recently at a session done here on the House side, headed up by Congressmen Kennedy and Murphy around the 21st Century Healthcare Caucus, and that we help support having to do with the nexus of healthcare reform and high tech. So appreciate that, and you're coming back to be with us again today, Blair. Thanks.
Yeah, ignore the date on that, by the way. Sorry about that. Well, hello everybody, and you're probably wondering, here we are talking hospitals after we're talking about value-based insurance design. What's the connection? Help me out here, please. Well, I guess beside the fact that it's the use of the term value, this really is all about what I think healthcare reform was about, which is really how do we get more out of our healthcare system? How do we really drive better performance out of healthcare? Because it is the imperative of healthcare reform, frankly, when you think about it. We've got to get cost down, we've got to get quality up, and that's really what we were trying to do. What was attempted through healthcare reform, and I think what is being attempted through so much of the efforts by insurers as well as providers like who we are. Let me start off, so that's sort of the common denominator. Get value out of healthcare. The second common denominator was they talked about incentives. They were talking about incentives for individuals. I'm going to be talking about incentives for healthcare providers. So let me first say who Premier is. Premier is an alliance of nonprofit hospitals, pretty unusual organization. We have 2,300 nonprofit hospitals that work through us. We have the largest clinical database in the country. And all these hospitals, 700 of those hospitals feed all of their clinical data into this database. It's a data repository, which enables them to share information, identify who the top performers are, benchmark their performance against the top performers, identify their gaps, and really then perform and improve against and try to fill those gaps or close those gaps. And if you think about what's been a problem in healthcare, in our healthcare system in this country, is how fragmented it is. Everybody's off in their own little silo, kind of doing their own thing. And that's been a problem because the ability to learn from one another has been undermined by that fragmentation. And what we try to do is overcome that fragmentation by uniting hospitals for the purpose of improving quality and reducing costs. That's what we do. So every day we work to help hospitals improve quality, reduce costs by basically uniting them. In this case, mostly focused on clinical quality and safety improvement. I'm going to talk about some of the things that are in the healthcare bill and specifically what we're doing and the implications related to HIT. So let's go to the next slide, please. So this is what I'm going to talk about. Now let me just, before I get into the payment reforms and healthcare reform, let me just point out the biggest problem we have had in improving quality and reducing costs is that if we help our members become the top performers in quality and the top performer in cost, so they're reducing their readmissions, they're reducing their complications, they're actually reducing their costs in their geographic area. Believe it or not, under Medicare, you're actually losing out to your competitors. Your competitors are at a competitive disadvantage under the current payment system if you do the things I just talked about. Okay, so think about this. If you improve your quality and you reduce your cost, you're going to lose out to your competitors if you do that well under the current payment system, because the current payment system pays for every procedure that you do, irrespective of how well you do it, and whether somebody returns to the hospital and has a readmission, and whether there's a complication or what other kind of event occurs. The incentives in the current payment system are completely messed up. So a large part of healthcare reform was about aligning incentives, the same kind of thing that you all were talking about, on aligning incentives for individuals, so individuals aren't, they act in a more health-conscious fashion. Same kind of thing needs to be done in our healthcare system for providers. And that's what healthcare reform does. I'm going to talk about some of these areas, and they divide into two areas. One are pay-for-performance kinds of reforms. And they essentially mean that you're going to be paid, either incented with more payment or penalized with less payment based on your performance. That's one kind. The other is something which is more bundling. So bundling of payment with the idea of, and this is delivery system reform is the way it's been called, or what it's been phrased, to try to create different incentives in the payment system. I'll describe those in a couple of minutes. These have massive implications for hospitals and healthcare providers. Massive. The level of change required to do these things that we're talking about, from the standpoint of data, as well as changing the way our healthcare system functions overall is huge. So the amount of change that hospitals and our healthcare system is going to be going through over the next decade is very dramatic. I cannot stress this enough. It's going to be really challenging. I'm going to talk about some of the things that they're going to need to do to get through this period to change the way it works. But basically, think about it. We've had 40, 50 years of a payment system that basically incentivizes every time you go to the doctor. It incentivizes everybody in a little silo. So the hospitals are in a silo, the physicians are in a silo, home health is in a silo, everybody's in a silo, they're paid separately. So you don't think across those silos. And you don't necessarily try to collaborate with those people across those silos. So this is changing all those dynamics. This is a very different world, and it requires a different set of information, a different set of practices, cultures, etc. So that's what I'm going to talk about, is all those things. Next slide. So here's, from the standpoint of the hospital community, and I just handed out some of these slides here. From the standpoint of the hospital community, these are sort of the major provisions impacting them. And I'm going to focus in on the quality provisions and the delivery system provisions here. Okay, you guys still with me? Everyone's still awake? Everyone's kind of fading off here. Come on, hang in there. I know I'm the last one. It's been going for a long time. I'm tired. Okay, next slide. Okay, so let's just talk about pay for performance. So this is the first one. So slide, next slide. I'll go fast so everyone stays awake here. Come on, let's go. Neil, will you just stop distracting everybody? Okay, thank you. So pay for performance. This is value-based purchasing. Some of you may have read this provision. Basically what this does is in October 1st, 2012, hospitals will be paid only 1%, but 1% of their DRG payment will adjust based on their performance on various quality and outcomes measures. So currently these are reported online through Hospital Compare. People can find out how hospitals have done on these quality measures. In the future, not only will they report these, but they will also be paid based on their performance. So every hospital will be measured. They will be given a score. That score will correspond to a level of either improvement or attainment, and either you'll get 1% or you'll get 0%, or you could potentially, depending on how it gets designed, you could potentially get up to 2%. It all depends on how they move that 1%. But basically that 1% of DRG is going to change. Some will get 0, some will get probably more than 1%. Does that make sense? So if you're not performing well, you lose 1% of your Medicare payment. And that's a pretty big chunk of money. Most hospitals, 50 to 70% of their income is Medicare. This will be replicated by private payers, I suspect, as well as Medicaid as well. So implications are broad. Starts at 1%, goes up to 2% over the next few years. I wouldn't be surprised if in the out years they put more money into value-based purchasing. The president's original budget proposed 15%, was to be in value-based purchasing, and that was, you know, the 2009 budget. So that's value-based purchasing. Everybody get that? That makes sense? Yeah, question? A DRG is a diagnostic-related group. There are 740, I believe, roughly DRGs which associate with diagnoses. So if a patient has heart attack, it's a DRG. You're paid a set amount. It's a bundled payment. Okay? Good question. Fair enough. Do you really want me to do that? Okay, Neil's saying I should talk about prospective payment versus, it's basic, but essentially it's a bundle, and it says this is what we think it's going to cost you to deliver that amount of care for a patient with a heart attack. Okay? Next slide. This program was built on a demonstration project that Premier did, the Premier Alliance did, with CMS, and we organized 250 hospitals across the country, about 34 states, who looked at different quality measures, and this is their level of improvement. And as you can see, get to the point where and this is their average improvement. This got to the point where you couldn't really improve anymore because there's like a data issue. You can't get any higher than this because of sort of data noise that exists in collecting data within hospitals. But the level of improvement was astounding. This is one way of measuring. We also measure a all or nothing score, which means that you only get the score if all the patients get all the measures, and the level of performance improvement was dramatic. Absolutely astounding. So what this proved is that payment as well as transparency drives better results. Okay, what a shock in America, but if you incentivize people, and this is what you're saying, what a shock, it actually delivers results. Okay, so no one's going to be too surprised by that, I guess. But that's what we've done now. The program was designed based on what we did with CMS and really was a direct replica of our second version of our demonstration project. Next slide. Now the second area is a penalty. This is not under value-based purchasing, hospitals can be rewarded, so they could actually get even a little bit more if they're a top performer, or they can be penalized. This is a straight penalty. So this is pay for performance, but it's really not pay, it's penalty for performance. Or for non-performance, excuse me. So penalty for non-performance. So basically what it does is it says starting in October of 2012, hospitals will start to be penalized if they have more readmissions than what is expected. So their observed to expected readmissions is more than it should be. Okay? So they start getting penalized. They can get penalized based on a formula up to 1% of their DRG payments. Okay, so 1% of all their Medicare payments can be penalized. That's the first year. Second year is 2%, third year is 3%, and it's capped to 3% thereafter. So between readmissions and value-based purchasing, hospitals have 5% of their Medicare payments potentially at risk. Okay? So this is a big change from where it is today. And I can talk a lot about the different kind of measures and so forth that are going to be in store for hospitals, but this has big implications for the way the healthcare system and healthcare delivery will work in the future. Next slide. Then the last provision I want to mention, which is also a non-pay for poor performance approach, is the penalties for hospital-acquired conditions. And starting in October of 2012, hospitals will be penalized if they are in the bottom quartile of having hospital-acquired conditions. So if you're a poor performer and you've got a high incidence of risk-adjusted hospital-acquired conditions, you will lose 1% of your Medicare payment. Okay, add all this up, 6% of Medicare payment is at risk.